The title of my talk today is Strengthening the External Locus of Hope, Suicide Prevention in Youth. And what I will be doing is kind of showing how hope theory, which is actually something by coincidence that my colleague Dr. Hellman lectured on this morning, but how hope theory can be useful in helping us not only to conceptualize the horrific dynamics that result in deaths by suicide among young people, but also can be leveraged in us thinking about how we can, be useful in reducing suicide in this population. And so my agenda for this afternoon is to go very quickly over the epidemiology of suicide in general and in young folk. We'll talk about the status quo of what helping professionals and social workers and psychologists, psychiatrists are doing now to respond to this crisis. And then we'll talk about hope theory as a useful heuristic for understanding best practices in screening, assessment, and treatment of suicide risk in adolescents and youth. So epidemiology, when it comes to suicide, is always a terribly depressing thing for us to think about because this is a huge problem, especially in the United States. We've seen a 33% increase in the suicide death rate over the past few decades, and it doesn't look like we have plateaued yet. Every time this data gets updated, these numbers seem to get worse. What that looks like in terms of people impacted by this across the country is about 47,000 people dying every year to suicide. It's the 10th leading cause of death, and more people die by suicide than in motor vehicle accidents. And these numbers are so big that sometimes it becomes almost dehumanizing. It's hard to wrap your mind around 47,000 people dying every year. And to kind of break it down in a way that maybe is a little easier for us to understand, what this means is that in the amount of time it takes me to deliver this talk over the next hour, about 95 people across the United States will attempt suicide. And of those 95, about 5 of them will die by suicide. And it's a very depressing statistic, really, and it's something that should give us all pause. And unfortunately, it's also a statistic that's not terribly useful to us as clinicians and as social workers. When a person has died by suicide, it's too late for us to help them in particular. What we do as helpers is we transition to what's called post-vention mode, where we think about how we support and intervene with those people who were close to the deceased, especially those people who were psychologically close to that individual. And we try to reduce things like contagion in communities. But for the actual person, it's too late after a suicide. So the numbers that we really need to be thinking about are less the actual death rate, which is only significant in as much as we see that number go down over time, as much as what the number we need to be thinking about are those people who are experiencing severe suicidality, but have yet to die by suicide. And so what this looks like, if we take some CDC data, we know that for every person who dies by suicide, about 12 others will attempt suicide. CDC gets their data primarily from emergency rooms, and we know that a very large percentage of folks who attempt suicide actually don't end up in the hospital. So if we include SAMHSA's data, which also integrates clinical reports of suicide attempts, we know that for every person who dies by suicide, about 30 will attempt suicide. If we broaden it a little further, we know that not everybody who has clinically significant suicidality actually makes an attempt. If we include folks who simply report having a suicide plan, so there hasn't been an attempt yet, that ratio goes 1 death to 60. And if we include serious suicidal thoughts that are serious enough to need some clinical intervention, but no plan, the ratio goes 1 death to 207 people who have clinically significant suicidality. What this looks like in the United States is about 9.5 million people in our country every year experiencing suicidality that is severe enough that they probably could benefit from some clinical interventions. This slide also illustrates one of the biggest challenges in suicide intervention, because despite the very large number of people experiencing suicidality, death by suicide is actually a very low frequency event. So it's really hard to research this, and a lot of our instruments have very poor predictive values. Essentially, most people who experience suicidality do not then go on to die by suicide. So we have basically a form of a needle in the haystack kind of problem when it comes to suicide prevention, where our only options as clinicians are to throw a wide net and try to intervene with as many people as possible. Now, when we look at those 47,000 people who die by suicide every year, and we start to dig into the data to look about how this is impacting youth, we have some what appears to be on the surface good news. It turns out that among folks who are 24 or younger, they actually represent a relatively small percentage of the overall impact of suicide in our communities. It is much more common amongst older adults or middle-aged adults. And so why so much focus on youth? And there's a few big reasons why we have so much energy and focus on this specific population. The first reason is because the death rate amongst youth is lower for all reasons compared to other age groups. Yet among people who are 24 years old or younger, it's the second leading cause of death behind only unintentional injuries. And so because it is something that is felt more profoundly, because the death rate is actually lower amongst youth in general, that's why we have so much focus. And not only that, but we have seen some alarming trends in the past decades. Since 2007, we've seen a 56% jump in deaths by suicide in young people. And some research shows as high as 20% of high school students reporting having had a suicidal thought. And so we have a focus on youth because this is a big part of what it means to reduce mortality in general amongst young people, because this is such a predominant cause of death. And also because we see this as something that appears to be getting worse in these communities. And there's some concern that we may see in coming years, the suicide death rate amongst youth start to eclipse that of other age demographics. And so one of the first things that a lot of folks will ask when we look at these kinds of concerning statistics is, why is this happening? What is driving this rise in suicide amongst young people? And one nice way for us to kind of start answering that question and exploring that is by digging a little deeper into the data that can give us some clue into some etiological hypotheses we might have about why this is happening. This is a problematic set of data because when we talk about suicide risk purely in terms of gender, it has the effect of erasing non-binary and sexual and gender minority populations who they themselves are disproportionately impacted by this. And we'll get to those populations in a few slides. But for now, we'll use the sort of simplified construct of male and female to talk about suicide risk in young people. We know that boys and men are much more at risk of dying by suicide compared to women, about 4 times the risk. And we could look at data like this and say, well, apparently suicide is a male problem, and we should really be focusing only on men and boys in terms of our efforts. But what we know is there's sort of a paradox in the data, because if you also look at individuals who seek help for suicidality, that women are about 3 times more likely, women and girls, to ask for help or to receive services than men and boys. And the hypothesis that's emerging in the suicidology community is primarily around this idea that men feel and boys feel the stigma of mental health problems so profoundly, and they are so attuned to those stigmas and that fear of appearing weak or vulnerable, that they'd rather die than ask for help. And really, this is what we're conceptualizing in terms of what it means for toxic masculinity, which we rightly so focus a lot on how toxic masculinity affects girls and women. But in this case, this is what toxic masculinity looks like when it hurts men. And it's something for us to really pay attention to, especially when we consider about how we can do a better job in intervening in terms of engagement with men and boys in ways that they are more comfortable actually engaging in services and instead of taking their own life. Now, as I mentioned, sexual and gender minorities are disproportionately impacted by this, and this is very true among youth in particular. Among youth who identify as a sexual gender minority in general, they are about 5 times more likely to attempt suicide compared to their cisgender peers. That even goes up higher to 8.5 times higher risk if there is familial rejection. And so you can see where the ideological sort of answer with some of these populations just jumps out at you. This idea that being rejected by one's family is a major driver of suicidality amongst some populations. We also see in some subsections of the sexual and gender minority populations, in particular transgender boys, that about half of all transgender boys will attempt suicide by the age of 25. And so, grossly overrepresented and over-impacted by this issue in that population. And of course, this introduces lots of interesting ways of us to conceptualize why this is happening, the role of discrimination or oppression, or again, family rejection, attachment disruptions. But we also have this emerging sense, and this is very prevalent in Oklahoma, of what it looks like when people have self-hate that is connected to an internalized sense of homophobia, when one's values and culture come into clash with their sense of identity. And that's something that we've been looking at a lot in terms of what drives this in this population. Nationally, we also see among youth very high rates of suicide in American Indian youth. Of some of the highest of any demographic. About 1 in 4 American Indian youth will attempt suicide at some point in time in their life. So dramatically over impacted by this problem. And in Oklahoma, something that always jumps out at me is we have in our population, about 3.5 of the Oklahoma population is an American Indian male. And that 3.5% of our population make up 25% of our overall suicides in the state of Oklahoma. And so again, interfacing with youth, in particular, some of these minority youth, is a critical part of what it means to reduce the overall impact of suicide on young people. And of course, in terms of etiology, when we start looking at the data around American Indians, we can get this sense of suicide as sort of a post-colonial disorder in a response to sort of historic trauma. And this idea of ongoing, cumulative, unresolved trauma in communities and what that looks like. Also, there's a sense that contagion is a huge issue in many American Indian communities, where you have one suicide and a week later, all of a sudden there are 3, 4 more, and how being connected to somebody who dies by suicide increases the risk profile of the other individuals in that community. Now, when it comes to drugs and alcohol, we kind of get into more of a behavioral or maybe even mental health sort of domain in terms of looking at the data. And we know that about half of youth who die by suicide also have some indication of substance misuse in their profiles. And so we know there's a very, very big role to play in terms of alcohol and drugs in the suicide death rate among youth. And, having alcohol use disorder exponentially increases somebody's risk of dying by suicide. And it's even more true if somebody is injecting substances. And a lot of how we understand what's going on here in terms of etiology and what's driving all of this is more connected to how we understand the role of impulsivity in suicide. And we know that adolescents in particular, as a baseline, just developmentally have more problems with impulsivity than adults do. And so you can imagine how having that sort of baseline that's already a little more vulnerable to suicide, how when you add, alcohol and drugs to the mix, and how that can really alter their inhibitions in ways that can become fatal if they're in a place of pain and suffering and thinking about suicide. We know that trauma plays a huge role when we look at ACEs and the correlation between ACEs and suicidality. You can see that the higher the ACE score, the more connected that is with a suicide attempt later on in that person's life. And so, having 4 or more ACEs in particular exponentially increases the risk of suicide. And sort of connected to all of this, I imagine some of you are wondering how we could talk about etiology for so long without also mentioning mental health. And it is very true that mental health is very much a big part of the conversation when it comes to understanding why so many young people make the decision to take their own lives. And, having major depression exponentially increases the odds that a young person will decide to die by suicide. And about half of people with bipolar disorder attempt suicide at some point in time in their life. And it's one of the leading causes of death among folks who have schizophrenia. But all that said, something that I always like to caution clinicians when we start conceptualizing why this is happening is for us to be really careful about a mental health bias when we think about why somebody's experiencing suicidality. Year after year, very consistent, this data, the surveys show us that a majority, around 54 to 56% of folks who die by suicide did not have a known or suspected mental health condition at the time of death. And I'm almost certain that a big chunk of those folks are people who slipped through the cracks and who we failed to diagnose them. But there's also this emerging sense in the suicide community that we need to get away from this mental health bias in terms of how we conceptualize the problem of suicide, because we know that that bias is causing harm, and that it's causing us to have blind spots as clinicians that is not giving the clients what they need from us. And we'll talk a little more about that mental health bias here in just a minute. Increasingly, where we've been putting a lot of focus is in more of an ecological perspective around suicide. When you look at the suicide death rate in individuals who die, and then you also take a look at what was happening in their life around the time that they died, we start seeing the context and the stressors in a person's life and how those play a huge role in this problem. Legal problems, financial problems, employment problems. About a quarter of all people who die by suicide have current physical health problems that are severe. And when we look at adolescents, what we start seeing going on in their life is a recent death in the family, a child who's struggling to cope with the separation of their caregivers, or a child who's struggling with their functioning at school, or is having elevated stress at school, or who is being bullied, or who is a bully, or who is stressed out by a lot of the new dynamics that emerge in terms of social media and how those play with adolescents. And one statistic that's really important for us to keep in mind when thinking about suicide in young people is that nearly half of young people who die by suicide take their own life within a few days of a major relationship crisis, an interpersonal disruption of some sort, usually a breakup or maybe an argument with a family member. And so we start to conceptualize the suicide, not just as what's going on inside the person, but what's going on inside them in relationship to what's going on around them. And of course, one of the absurdities of a lot of this data is I speak about these individuals as if they all belong in these little buckets. And what we know is that intersectionality is sort of the name of the game, and that many of our clients find themselves in one or more of these sort of categories of risk in areas where we can think about why it's happening and the sort of the etiology of their suicidality differently. And you can see how when we go through the data, that when we ask the question, why is this happening, that the answer is almost inevitably, it's complicated. The reasons people come to experience suicidality, including youth, are not homogenous. They're not the same. There's a lot of diversity in different ways to conceptualize it. And taking this and thinking about how we use this to inform our interventions is a big part of what we can do to improve outcomes for young people across the country. Now, again, as depressing as this may seem, this is all status quo stuff, right? This is the data right now. This is what it looks like. And it's natural for us to look at this data and to say, why is this happening? And then the next question we might have is, well, how do we reduce suicide amongst young people? What can we do to make this less of a significant problem in our country? And let me tell you something that's really uncomfortable for a lot of us to hear, but it's a hard truth that most clinicians do need to hear. And that's that what we have been doing, the status quo of clinical interventions that's been mirrored by this emerging crisis, is simply not working. That a big part of the problem in terms of addressing the suicide rate in our country is that we have a workforce that is underprepared to address this crisis, and that we have a sort of crisis of both screening, but then also competency in terms of treatment after positive screening. And this is something that, I don't have time to get into all the data, but that I've been spending a lot of time on at the university in terms of thinking about how we do a better job of preparing a generation of social workers and clinicians who are ready to do the hard work of suicide prevention and treatment in our communities. And so one of the things that we need to do when we consider about how do we reduce this is to have a clear-eyed view of what exactly are we doing right now, and what is the status quo of what mental health providers provide to the average individual who comes to them with suicidal problems or a suicidal crisis. And we have limited research on this for obvious reasons, but what we do know is something that should bother all of us. We know that there is a spectrum of responses that we tend to see in clinicians who are not properly trained to address suicide, but who nevertheless engage with suicidal clients. And I like to think of this as a spectrum from unethical all the way to the most adaptive and ethical thing they could do. On the unethical side of the spectrum, we have individuals, clinicians and helpers, who will interface with somebody and they will notice the signs and symptoms of suicidality in that individual. They'll meet with a kiddo and they'll see those warning signs. And for a variety of complex reasons, there are clinicians today who will not do a suicide screen. They will choose to ignore what they are observing in their clients. And that's something we need to be really bothered by and really be working against, because that's unacceptable, in addition to being very unethical. We also know that just above that, there's a very large segment of our population, and this includes parents, this includes teachers, it includes all manner of helpers, whose reaction to the suicidal adolescent is to minimize it. You can imagine how it might feel to be a young person who goes to a counselor or a social worker and discloses their suicidality, and the response they get from that individual is, well, you're not really thinking of killing yourself, are you? And how they get invalidated by that person. It gets minimized. Or how many times have you heard a parent say, I know I've had my fair share of this, a parent says something like, they're just saying this to get attention. And that's a really common dynamic we see in teachers and parents, and also in a lot of helping professions, unfortunately, that we will minimize the risk. And of course, my response as a clinician was always to tell the parent who was alleging that their child was trying to get attention that, well, if what they need is attention, for crying out loud, let's give them some attention. That's better than the alternative in this case. We know that there's a big segment of our clinical population sort of in the middle, who don't have full training, but have been exposed to enough training to where they have some sense of what they should do. Maybe they have a sense about how to develop a safety plan, or if they're a little outdated, they may try to do a no suicide contract. But this is sort of the clinical segment of our population that I call the winging it segment. These are folks who don't really have training or any sort of model that they're following, but they're more just trying to wing it and get by. And they're well-intentioned, but there can be problems that emerge in all of that. But when you have a workforce that is not properly trained in suicide intervention, the most adaptive thing those individuals can do is to refer that person to somebody who does know what they're doing. So whether that means referring that individual to a supervisor or to a mental health, emergency service of some sort, a crisis center, or more often than not, a hospital is where we refer folks. When we have a suicidal client in our office, an adolescent or a young person especially, and we don't know what to do, we send them to the hospital, and the hospital is going to check in on them and make sure they're okay. And this is really problematic. This gets back to what I was talking about earlier in terms of the mental health bias that we bring to suicide treatment in the status quo that is just not helping a lot of our clients. And the problem is when an adolescent goes to the hospital, they don't move in for 6 months. They don't get long-term treatment in most circumstances. What usually happens is a young person is admitted to the hospital, and they go to one, maybe two groups. They may get some medication. They may get some individualized attention from a psychiatrist or maybe a therapist. But once that adolescent is no longer in clear and imminent danger of dying by suicide, they're usually discharged from that hospital. And let's be really clear about what we mean by that. When we say not in clear and imminent danger, what we mean is that the adolescent themselves has said the words, I'm not going to kill myself. That's how we determine clear and imminent danger in most cases. And the reality is that they're not getting their suicide treated when they're inpatient. You don't go through something like that in the hospital and then come home and the suicide's all better. And it's not really an indictment of hospitals. What we're trying to say in the suicidology community is that hospitals serve a function of stabilization and of safety, but that the ultimate treatment of suicidality needs to be occurring in outpatient settings, not in hospitals. And unfortunately, what happens is a lot of clinicians will have a client discharged from the hospital from suicidality, and they'll pick up their treatment plan right where they left off, dealing on some other issue without actually treating the suicidality. And that's one huge sort of blind spot we have in a lot of practice. And something that I tell clinicians that I train that is disturbing, but it's true, is that we need to be really careful about how we conceptualize the role of a hospital in treating our clients, because hospitalization is a risk factor for suicide. There is no point in time in a young person's life when they are at higher risk of dying by suicide than in the first few days and weeks after they're discharged from a hospital. And so not only is hospitalization not fixing the problem, in many ways it makes it worse for clients. And so when we say that the most adaptive thing we can do when we're not trained is to send somebody to someone else, that doesn't really fix the problem. We need to have a workforce that's ready to do the hard work of building capacity and competency to provide these services themselves. And so for the rest of our time, I want to go over some of the best practices that we know in terms of actually doing this work. And we'll be using, again, hope theory as a heuristic to kind of guide a lot of our thinking. Now, first is screening, or talking about suicide. The first thing to think about is that in addition to the risk factors that we were talking about in terms of epidemiology, the sort of large categories of individuals who are at elevated risk, we also have this concept of warning signs. And warning signs are dynamic, temporary, and sort of indicators of acute escalation of suicidal risk. And these are things that we can observe in people ourselves. And so obviously, if you have someone who's talking or thinking or writing about suicide, that's a warning sign that you pay attention and you move forward and intervene from there. Some of these are a little less clear, though. Things like when an adolescent says they are feeling hopeless or trapped, or they talk about experiencing unbearable psychological pain. Those may be things that we may think of in terms of mental health, but we may not always consider the risk and connection those things have to suicide. Again, the mental health bias becomes problematic because we tend to think of depression as having this strong association with suicide, which it certainly does. But we also know that when an adolescent is very angry or agitated or anxious, that those kinds of emotional or mood disturbances are actually higher risk factors for suicide than an adolescent who's depressed. And so not that we use this to rule in or rule out suicide, but when we make the decision to screen somebody, we need to be screening our angry teenagers, our agitated teenagers, not just our depressed teenagers. There's also this idea of there's big changes in different behaviors, if there's family conflict, bullying, or any language about feeling like a burden, especially when you combine all these things with easy access to means, that we need to be asking a suicide screening question to an adolescent. Now, in terms of tying in hope theory, the way hope theory can help us to conceptualize suicide is actually really interesting. So just as a quick review, hope theory is a very specific but simple and elegant formula, which is essentially somebody has a goal, they have willpower to pursue that goal, and they can identify pathways, or they have way power to arrive at that goal. Now, when we map suicide to hope theory, the goal becomes to reduce pain. And so this is how you would conceptualize it with your client. Usually it's psychological pain. Usually it's sort of this unbearable, sort of sadness or relationship stress that is creating distress in the person. And you need to conceptualize what that is. Now, normally we all have pain in our life. We all have distress and discord that comes to us. And most of us have quite a bit of willpower to escape from pain. That's a very human nature kind of thing. Most of us, when we're uncomfortable, we want to try to regain a sense of comfort. And so having willpower to reduce pain is pretty normal. But what happens when the pathways available to us to reduce pain and suffering are blocked? What happens when I'm not happy with the way things are? I want to change them, but I can't find a way to make that happen. What we see is something very damaging happens to our willpower, and it's where it gets replaced with some other things. It gets replaced with rage. Rage is where a person turns up the volume, an adolescent who is throwing a tantrum, or they're trying to pursue their chosen pathways to reduce pain with extra energy and anger and rage. Eventually, for a lot of adolescents, that might actually lead to a suicide attempt, that rage. Other times, the rage doesn't work and they find themselves experiencing what we call despair. And despair is a really risky sort of emotion for somebody to be experiencing when they're experiencing unbearable pain. Because basically, there's lots of energy still, there's lots of desire to escape from the pain, but despair reflects the blocked pathway. It's not working. I can't figure out how to do this. Apathy might be how we would conceptualize your more traditional sort of depressed individual in response to intense psychological pain. And of course, all of this is what results in somebody having the very twisted realization that suicide is a pathway. This is where suicide becomes this sort of perversion of hope theory, where suicide is this ultimate pathway to achieve a goal to reduce pain. And this is why a lot of us have started to focus on our screening questions and those early conversations that we focus on this reality, this idea of what problem would suicide solve for you? How that helps me, when I ask that question, to understand what is the pain and suffering? What are the blocked pathways that are making this person so desperate that they're thinking about taking their own life? And of course, it gives us hope in terms of reframing it. If we could find some other way to get this pain dealt with, would you still want to die? Now, when it comes to screening and hope theory, one thing that I invite you to be really mindful of is it's very unusual for a young person to come to a clinician because their suicide is bothering them. Again, suicide is this weird solution to a problem for a lot of adolescents. What they come to you is to talk about this other stuff, the pain and suffering, the despair, rage, or apathy that they're experiencing, and that is their focus. And it's something that we can leverage when we think about doing a suicide screen. Now, the literature supports two persistent approaches, the direct and hierarchical approaches. The direct approach is exactly what it sounds like. You walk up to a kid or an adolescent or young person and you say, are you thinking of killing yourself? Are you having thoughts of suicide? Clear, direct, basic language. What we find is that can be very effective, and it's something we should be using pretty frequently in our interface with children and young people. A lot of times it's just that person has been waiting for the opportunity to disclose their pain and suffering to someone. And all you're doing is opening the door and giving them permission to share with you. Now, a hierarchical approach is more of a clinical approach, but can also be used by laymen as well. And what a hierarchical approach does is it recognizes some of these hope concepts, and it engages in a conversation with the kid or the young person around their pain and suffering, and then leverages empathy and connection around that issue to ask the screening question. So if you could bear with me for a second and kind of experience the difference. If I were to go to you as a young person and say, in a direct manner, are you thinking of killing yourself? How it feels to hear that. And then let's compare it to a hierarchical approach, where if I come to you and I say, I'm so glad you came in today. And I can see that things have gotten really dark for you and you're in a really, really bad place right now. And this breakup with your girlfriend has really got you upset, and your parents have been just such a big problem and a stressor for you as well. And you're really not sure what to do. And I'm so glad you shared this with me. And I'm wondering, when I talk to other young people who experience similar kinds of pain that you've just described, sometimes what I also see is that in the middle of this, they also start having thoughts of killing themselves. And I'm wondering, just given everything that you're going through with your family and with your ex, if that's something that you're also experiencing right now, if you're also having thoughts of dying by suicide. And so obviously the hierarchical takes a little more time, but it's a very effective way of engaging with a client in terms of a suicide screen that acknowledges sort of these dynamics we've been talking about in terms of hope theory. Now, when it comes to screening, this is everybody's job. The QPR modality is probably one of the most widely distributed modalities for training, and there are modules for just about any kind of helping profession you can imagine. And it's a simple process of training folks in those warning signs and risk factors for suicide amongst young people, and then training them also to ask a direct or hierarchical screening question. And when they have a positive question or a response, they move on to the P, which is persuade, where they say, will you go with me to get help? Let me help you get help. And then the R, which stands for refer, that where you literally take the person to the help. And this is something we've been doing a lot of work in the state of Oklahoma and around the country to train as many people as possible to do basic screening. But of course, once you have a positive screen for suicide, the next step is you need to do an assessment, again, to revisit hope theory. And this is some bad news I have for you. A lot of folks will use assessments to try to determine whether or not somebody should go to the hospital. And our assessments are about as good at predicting suicide risk in terms of death by suicide as flipping a coin. If you're using your assessment to decide whether somebody is low, medium, high risk of suicide, you're not really using it adequately, and it's not giving you good data. Of course, during an assessment, we make important decisions about hospitalization, but the fundamental role of assessment is conceptualization. The idea that I assess somebody to understand their pain and suffering, to understand those internal processes that are distressing them, to understand those external block pathways that are also distressing to them, and then maybe also to understand their suicide itself and what that looks like. To respect all of this, it's critical that we meet the client where they are. When you meet with a kid who's disclosing suicidality, you need to understand, what are their reasons for wanting to die? Can you help me understand the pain you're in? What am I missing? And this is so critical because most of us don't feel comfortable doing this. Most of us, when we interact with a suicidal young person, we want to invalidate them. We want to say, let me tell you why you shouldn't kill yourself. And that's a natural instinct we have, but it's fundamentally invalidating to a young person. And it's something that doesn't respect the decision they took to share with you. And so we want to validate their decision. We want to say, it was a good idea for you to come talk to me. I'm glad you came to talk to me. And I can understand, given everything you're telling me, why you would feel suicidal in the middle of all of this. Again, to sort of quote Marsha Linehan, the creator of DBT, we're talking about empathy here, not agreement or affirmation of the suicide plan. We're trying to connect with them. Sort of related to this is this idea of getting away from data collection. And I'm not opposed to a Columbia or a PHQ-9 or any of our other sort of standardized approaches to assess suicidality, but we need to balance those with engagement whenever possible. When somebody feels interrogated around their suicidality, you're less likely to get good information from them than if they feel that you have heard them, understood them, and connected with them. In many ways, when we talk about suicidal storytelling, which is sort of this engagement model of assessment, what we're talking about is really a treatment intervention. It's a connecting with the person and engaging with them is a form of relief from their distress. We know that social isolation is a big driver of suicidality amongst young people. And simply having a conversation and connecting with them is a form of intervention that will reduce their risk just by having a conversation with you. And so use that power when you're talking to a young person to really do some good. You know, could you tell me how you got to the point that you wanted to put an end to your life? I'd like to hear the story of what led you to consider suicide. Would you be willing to tell me your story? And what you'll find out is 9 times out of 10, they will give you so much useful information in a sort of open question that you could have collected with a spreadsheet or a data collection method, but you're going to get it organically and more powerfully through an effort like this one. Of course, there is lots of data that may not come out in terms of a suicide storytelling approach. And so eventually you do need to balance out this sort of engagement approach with some more traditional approaches. And there's some data that you just need to have as a clinician. You need to know, especially things like the means or method, or if there have been previous attempts, or if they have, any intent or timing data that they might share with you. Or, one of the biggest things that sometimes we forget to ask is their own assessment of their own suicidal risk. That apparently, the data shows, is more predictive of suicide risk than any of our fancy instruments. It's simply asking the person to self-evaluate their risk. And so this is what we do in assessment, is we connect with the client, understand those drivers of suicidality. And the whole purpose of this should not be to decide whether or not they go to the hospital. When we do an assessment, we do so because we're joining with the client to help them, with the young person to do treatment. And so treatment and assessment should go hand in hand in a suicide intervention. And when it comes to treatment, as I was saying, again, we look a lot at outpatient treatment these days as sort of the gold standard of intervening. And that hospitalization is for those extreme cases where we need some time to stabilize. And something that I always tell my students is that when your client is hospitalized and discharged, I would like you to be waiting in the parking lot for them. This idea that hospitalization doesn't fix the problem. It's part of a portfolio of interventions that we might use. But at the end of the day, the actual sort of treatment, the meat of the treatment occurs in an outpatient setting. Now, the first one may seem pretty obvious when we're doing treatment. Suicide needs to be the focus. And that doesn't mean that you're only talking about suicide every week when you meet with your client, as much as it means that you are only focusing on things that are relevant to the suicidality, the pain and suffering they've identified, issues with willpower, issues with pathways. Those are the things we're going to focus on in our interventions so that we can actually resolve their suicidality. One of the big things we do in outpatient treatment is what's called a safety or stabilization plan, which is a coping and behavioral plan of what they're going to do instead of suicide. And that's sort of a standard practice that's all over many different modalities. There's also an emerging sense that identifying these drivers and targeting drivers is a big thing that we need to be doing. With youth, we try to involve family and friends as much as possible, which is complicated because oftentimes a suicidal adolescent is very concerned about sharing that information with parents. But it's also a critical part of helping that person to find ways to get them connected with their friends and family and reduce social isolation. We ask for a delay, take it off the table, let's try treatment instead and reduce access to lethal means. So one last time, going back to our heuristic, in terms of hope theory, when we think about this is what hope theory looks when mapped to somebody in a suicidal crisis, what we try to do in terms of treatment is the goal is our treatment outcomes to reduce pain and suffering. That should be literally on your treatment plan. Your treatment plan goals are the client's desired outcomes in terms of that major driver of their suicidality. Of course, we also still have other problems. We need to be thinking about what are the pathways instead of suicide. And also oftentimes, how do we replace things like apathy, despair, and rage with motivation? And so a lot of the treatment ends up looking something like this, where we clearly target that pain and suffering in the adolescent, those treatment outcomes, and we use different techniques to build their motivation to pursue those outcomes, as we also use our interventions, which should function as literal pathways to achieve that goal in that adolescent's life. So motivational interviewing is something that kind of jumps out at you when you look at that previous sort of heuristic. And it's usually a really nice modality to have in your back pocket when doing treatment with suicidal adolescents. It can help you have conversations with young people about the decision to include family members. It can have you be useful in conversations around safety planning and
sorry, I dropped my phone. Sorry.
She did say that helps with frustration.
I think somebody busted into our audio there. I think they're done now. They're muted. There's also concepts in suicide treatment called reasons for living and reasons for dying that directly translate to motivational interviewing, sort of change and sustain talk concepts. And so this idea of when you hear reasons for living, you reflect and affirm them. When you don't hear them, you evoke them kind of process. Also, there's some really interesting literature out there in terms of a reverse trans-theoretical perspective with motivational interviewing. This idea that if somebody's in action or preparation stage for suicide, that you're trying to use MI to literally make them pre-contemplative about suicide. But especially it's a big transitional modality in terms of getting somebody ready to engage in the difficult interventions we're going to use as pathways to solve their suicide crisis. Now, most of you are probably familiar with CBT, so I'm not going to spend too much time here. A lot of times there are unhelpful thoughts that can be heard during an assessment, and when you hear those, you conceptualize them as part of a profile of drivers for that adolescent. And if you hear cognitive distortions, then it makes a whole lot of sense to target those. Or more often than not, in young people, what we see is sort of emotional dysregulation. This idea that, sort of taking a dialectical behavior therapy approach where we use chain analysis to really deconstruct the series of events that resulted in a suicide attempt. And then, of course, integrating sort of the DBT missing links analysis to develop adequate coping skills for actually responding to all of that. But one of the challenges with a lot of these modalities, and these are some of the most popular ones for treating adolescent suicide, is they kind of overlook a big part of the dynamic here, which is that whenever a adolescent is experiencing suicide, or a young person, is that when we try to solve their problems with intrapersonal interventions, like internal interventions, that we kind of ignore reality, developmental reality and sort of social reality, that a lot of these individuals, although they have increasing autonomy, are not fully autonomous. And they're very dependent on adults, parents, and other caregivers. And they don't always have control over their pathways. In fact, in many cases, the pathways to solving their problems are externally located, which means also the axis of control is external. And so as helpers, we can't just focus on the internal with an adolescent. We need to be thinking about how we help build the external locus of hope. How do we increase pathways in families, school systems, even systems like juvenile bureaus, and other areas where hope can be really limited if we're not making active efforts to engage in those levels of the systems. You could look at examples of more sort of internal processes to solve external problems, like internal and interpersonal psychotherapy, which is emerging as a very appropriate modality for a lot of adolescents because of the nature of role disputes and suicidality in young people, and also the challenge of role transitions in young people, and how interpersonal psychotherapy is a nice way of targeting that. But we also have other modalities like attachment-based family therapy, which really conceptualize the family interactions and problems in family interactions as a form of blocked pathway. And so we engage with the suicidal client and their family, understanding that it's the relationship problems between that child and their caregivers that is a big sort of blocker of pathways, and that unless we engage in improving those attachments and those relationships, we're not going to get very far with that kiddo. And so here's some examples of how that might sound. When a kid says, I'm feeling bad, I just want to go to my room, I don't want to talk to anyone, especially my parents, it would be embarrassing and they don't know what to say anyway. What an attachment-based family therapist would do in that moment is what's called a relational reframe, where they'd say, you'd rather kill yourself than feel embarrassed or make your parents uncomfortable, where it really brings it into focus, where the problem is less on the client's suicidality as much as it is their reluctance to use their parents as a secure base. And we could go on to many different examples, like things like multisystemic family therapy has emerged as a common practice and efficacious practice in terms of reducing suicidality in youth. And this goes beyond families to really thinking about how we improve dynamics in peer groups, in school systems, and community and culture. And so, as we think about this, and I'm cognizant that I have only got about 60 seconds before I need to stop for some questions, I wanted to end on this problem of hope as a parallel process for a lot of folks who maybe aren't feeling so confident about their ability to do this hard work. And it's ironic because oftentimes as I'm training clinicians and social workers in hope theory as a heuristic to guide their work with young people and other clients in crisis, I often encounter a problem with the hope of the clinician themselves. that they themselves have some serious doubts about their ability or their, competency to pursue those pathways. And it makes sense to me. Suicide is a high stakes interaction with a client, and it's one of the highest, most intense things we do with a lot of our clients. And it's normal to doubt ourselves. It's normal to worry that we'll miss something, or to question our ability to really be useful to our clients, or even to experience a little bit of panic. And something that I tell, a lot of clinicians and my students that I find comforting is when we're in a conversation with a young person who's suicidal, that by definition, that young person is ambivalent about dying by suicide. Their very presence in your office is an act of hope. They have pursued a pathway. They made the decision to come in and talk to you, and they made the decision to share this information with you. And the truth is that there is so much hope in a suicide assessment and in a suicide treatment planning, and that you need to affirm that and grab onto that and use the power that's in that hope, that they've made the right decision. That it's such a wonderful thing that this person has made the decision to share their pain with you. And you need to affirm that. Let them know they made the right decision, and that they've taken a hopeful step. And, that we honor this decision and not let our own doubts and our own hope problems become something that cause us to reject or refer, as much as to lean in and be a critical part of what it means to saving a young person's life. All right, so here are my references. I have those on the handout that I'm sure Gal can share with you later, but I'm going to stop sharing now and take some time for some questions.
Christina?
All right, so we have a couple of questions for you. Thank you so much for that lecture. The first question is, what about hope theory with persistent suicidality?
Yes, so persistent suicidality is a big one, and that's one where I think a lot of the DBT kind of skills really make a lot of sense to me, with sort of the recurrent suicidality. Also, when I think about hope with the kiddo who is got recurrent suicidal behaviors, something that really comes up is this idea that we are at elevated risk of people discounting those behaviors. What we need to be thinking about when somebody is chronically suicidal is that they, with each subsequent suicidal sort of moment, are at elevated risk and higher risk, and they kind of build on each other. And so we shouldn't have this instinct of thinking that because somebody is chronically suicidal, that somehow makes their suicide less significant. It actually is the opposite. They are at higher risk because of that. And usually the interpersonal, I mean, my experience has been with chronic suicidality is usually there's a pretty strong trauma component there. And so you may find yourself needing to get creative in terms of pathways. In ways do you think about, how do I help this person to either cover or uncover their trauma, as we say in practice, right? Are we going to dive in the deep end and really understand what happened and try to unpack that? Or are we going to really work hard on identifying those coping skills that can help us get through a dark moment without needing to experience suicidality?
Thank you. I just want to let you know, John, that you have some compliments coming to you. Some participants said it was so good, we wish it could continue. We do have a couple other questions. What suggestions for training do you have for an LMHP who works in an ER doing suicide assessments?
Ooh, that's a really good question. Honestly, for me, in an ER, like that's one place where universal screening and persistent screening should be present. And most ERs are already doing the universal part of that. The persistent part, not so much. And so what I would like to see in emergency rooms is that pretty much anybody who comes through there gets asked the question a couple times. There's all kinds of reasons that somebody might fill out the PHQ-9 or the Columbia or some other instrument in your lobby. And they may make the decision in that moment to say, you know what, I'm not going to tell them about my suicide. And as a physician or somebody on the front lines, if then they come into interface with you and you're seeing those warning signs, it doesn't really matter they said no in the lobby. You're going to ask them a second time. And then if you see them again a couple days later when you're checking on them, you're going to ask them again. And this idea of constantly and persistently doing screening as being sort of something for us to really think about. And then on the other side of that, in emergency rooms, is thinking about, what we can do when we have a positive screen to be effective referral sources to actual long-term treatment. And sort of the short version of it is, and I'm a little biased here because a lot of my research is on CAMS with Dr. Jobs, is to find a clinician who says they do CAMS and refer them to that clinician, is my advice to people who do lots of screening. And most of our agencies in this area and across the country are increasingly training their staff in a lot of these modalities. So you can usually pretty quickly find a referral source that will give them good outpatient treatment for their suicidality.
Thank you. We have one more question. Do you find that religion or spirituality makes any difference in the decision to commit suicide?
Absolutely. It's a huge source of strength. It also can be a liability. So we can look at it from both perspectives. But when a person has religious or cultural beliefs that sanction against suicide, that condemn suicide, that is typically seen as a strength in most individuals. And so being able to connect them to those sources of support and those values is always a good idea. With the caveat that in some cases, conflict, especially what we were talking about in terms of interpersonal or intrapersonal conflict inside the person with their own belief system, can be a little bit of a liability. And, the obvious example is, somebody who is transgender and Catholic. So they have a religious belief that may be very profound and important to them that is clashing with a personal identity. And that's a moment where clinical work can't just simply turn to religion as a solution to the problem. We need to have a complex conversation about their values and how they can kind of make sense of all of that.
We had one last question pop up. Actually, two questions. We'll try our best to answer them. We just have a couple minutes left. Any suggestions when handling smaller age children displaying suicidal thoughts, behaviors, statements, age 4 through 8-ish?
That's a tough one. I mean, we've been seeing a lot more of that. Fortunately, that age group is still very uncommon to experience suicidality, but just anecdotally, I know that a lot of my students are encountering that in their caseloads and practicum and stuff more often. And the answer, as is with the case with a lot of children-focused work, is that the research is just not there. And so when you have a young kid like that, usually there's trauma, not always, but usually. And usually these sort of family-focused interventions are where you're going to have your best luck. When it comes to hope with a little kid, 4 to 8 years old, they don't have a lot of autonomy. And so a lot of their pathways are immediately controlled by the adults in their life. And so finding some partners and building an alliance with parents to provide good supervision, good means restriction, and also to think about how we can do things to improve sort of their relationships is often what we turn to in those cases.
Awesome, thank you. What about the ER situation where the use is intoxicated, is kept, and says later that he is not suicidal, so he is discharged without ever talking to a therapist?
Yeah, this is a great example of something that comes up a lot. That's like one example of lots of situations that come up like that. And with youth, this is particularly challenging. Usually a call to their parents or caregiver might be warranted just to make sure they're aware there was suicidality if they haven't already been advised. But regardless of the age of the client, we have to acknowledge the limits of our power as clinicians when interfacing with clients who are suicidal. The very truth of the matter is that there's very little I can do to control another human being. There's actually nothing I can do to control another human being. That's impossible. People are autonomous. It's sort of the reality of the world. And what I would say to folks who are concerned is that you have to, kind of accept it for what it is. And if a client says, I'm not suicidal, then they're not suicidal. that's what they told you, and that's what you put in your note, and you monitor them if you can. But unfortunately, this is one of those things where, and with kids, we get real uncomfortable with this because kids do have limited autonomy in so many domains, but this is one of those huge high stakes domains where they actually have quite a bit of autonomy. If a kid really wants to kill themselves, we can do things to try to stabilize them, but all we can do is have this supportive role. We can't actually keep them from doing that. And that's something that in working with suicidal clients is very exhausting. It really messes up our self-care. I know that there's probably people on the call right now who have lost sleep worrying about clients before, and who have experienced the sort of stress we have when we're not so sure if they're going to be okay. And all we can do is all we can do, right? We can do our best. We can give them the absolute best evidence-based, screenings, assessments, and treatment when they accept them. And then we also have to have, sort of the serenity prayer of the wisdom of knowing those things we can't control also. And it's a tough thing with kids though. I think when we're talking about youth, we especially feel like that's an unsatisfying answer to that question.
Thank you, John. Thank you for this important and very, very interesting lecture. I suggest you will take a moment and take a look at the chat and read all the wonderful feedback that you got. You deserve it. And so thank you. Thank you very, very much. People here asking for something to continue. So I'm just giving you an idea to start thinking.
Okay, well, that's good news. This is normally a 4-hour talk that I just squished into 50 minutes. So there's lots more to talk about, and I'm always happy to be the one to talk about it. So if you need me to consult with or anything, I'm happy to have those conversations.